thankful to Dr. Kundavi, Dr. Vasundhara, and Dr. Sindhu for keeping this meeting going on. And I'm grateful to Dr. Sachin Kulkarni and Dr. Sharayu Mohite for accepting our invitation. And Dr. Vani and Dr. Vijaya, they are the part of our TAPISAR family, and I'm thankful to them too. Yeah, the topics chosen for today's meeting are quite apt because 90% of our embryo transfers these days are FETs, and estradiol treatment is the mainstay in the preparation of the endometrium, and I'm eagerly waiting to listen to the today's topic. So the second one being the uh, this one, blast transfers, no? Also becoming routine in the IVF centers, and we are able to bring up the IVF success rates up to 60% these days. No, same time we can also prevent multiple pregnancies with single blast transfers. No? So with this brief introduction, I request Dr. Sindhu to take it forward, Dr. Kundavi to take it forward in this meeting. Yeah, thank you so much.
Over to you, Sindhu.
Good evening, everyone. Thank you, sir. So as we all know, Journal Club happens every fourth Wednesday from 8 p.m. to 9 p.m., the TAPISAR Journal Club. Vasundhara ma'am, can you kindly introduce the chairperson for the first session?
Good evening. It is indeed a great honor for me to introduce Dr. Vani Pujari. She is a director at Akshaya Fertility Center and Women's Center, and she's a president of Salem chapter of TAPISAR. She's a joint treasurer of TAPISAR, and she's a fertility specialist and laparoscopic surgeon with great academic interests. Kindly take over the session and go forward with introducing the speakers and take charge of the session, ma'am.
Thank you, Vasu. Thank you, Sarat sir, and everybody. And great to be a part of TAPISAR. And thank you for inviting me for this session. We'll start the session, and I think we can start the session, right?
Yes, Vani. Yeah.
Please introduce our expert.
Okay. So, can I have this slide?
Ma'am, are you able to see the screen, ma'am?
Sindhu, is there no? I'm able to see it very clearly.
Yes. Okay. Dr. Mahite is a fertility consultant at Jahangir IVF Pune and at Novo Solitaire Care Karadi Pune. She has fellowship in reproductive medicine under Dr. Sachin Kulkarni, diploma in reproductive medicine at IBC Dubai, first rank with distinction, international faculty for IVF courses at IBC Dubai. Welcome, Dr. Mohite, as an expert. And do we have the speaker's CV?
Yes, ma'am.
Yes, ma'am. The speaker today is Dr. Pallavi. She's going to talk to us about the duration of estradiol treatment and its effect. Dr. Pallavi is a consultant reproductive medicine, Pristine Hospital, Sunanda IVF Center, Kolhapur. Extensive clinical experience in obstetrics and gynecology in renowned institutes such as JJ Mumbai, Kama and Albus Hospital, Mumbai. She has got a lot of interest basically around reproductive medicine and infertility. Welcome, Dr. Pallavi, and we are eager to listen to you today. Thank you.
Yeah, thank you, ma'am. Shall I start?
Yeah, please go ahead.
Yeah, just a minute, ma'am. I'm sharing my screen. Is it visible, ma'am?
Yes, please put it on slideshow.
Yeah.
Yes, doctor.
Yeah, thank you so much for all of you for giving me this opportunity to present in front of you. Yeah. In today's discussion, we are going to discuss about the duration of the estrogen in frozen embryo transfer cycle and its outcome. I am going to present first paper. We are discussing here 3 papers. Out of this, I am going to present first paper, which is by Borden et al., with title Prolonged Estrogen Treatment Prior to Frozen Embryo Transfer Decreases the Live Birth Rate. This is an observational cohort study which include all single autologous frozen thawed blastocyst transfer. It is performed between July 2012 and December 2015. It took place at University-based Reproductive Medicine Center. The aim of this study is to evaluate if the duration of the estrogen treatment prior to frozen blastocyst transfer affect the live birth rate. And secondary aim is to assess influence on biochemical pregnancy, clinical pregnancy rate, early pregnancy loss, and neonatal outcome. The study included the patient who require ART with IVF or ICSI, those with age less than or equal to 42-year-old at the time of ovum pickup, with single autologous frozen thawed blastocyst transfer. Artificial endometrial preparation was used for endometrial preparation, and regardless of patient's ovulatory status. Exclusion criteria were cancelled embryo transfer, then FET from arbitrified oocyte procedures, embryo donation procedure, natural endometrial preparation, GnRH agonist pre-treatment. Total 1,377 frozen thawed blastocyst transfer from 852 women were analyzed. These patients are divided into 4 groups. Group 1, those who received less than 21 days of estrogen. Group 2, those who received 22 to 20 days of estrogen. Group 3, those who received 29 to 35 days of estrogen. And Group 4, those who received 36 to 40 days of estrogen. For this, during endometrial preparation, they had started oral estradiol administration 4 milligram twice a daily or transdermal patch delivering the same dose, that is 0.2 milligram per day via 2 patches. It is started from day 1 of menses, and the follow-up appointment was given based on patients or centers availability. And this leads to variation in duration of estrogen treatment ranging from 14 to 48 days. Progesterone support is started once the endometrial thickness is more than 6 mm, or if serum progesterone level was less than 1.5 nanogram. Embryo transfer timing was fixed, which is at blastocyst stage, day 5 after the progesterone start, and the luteal phase support was continued until the 12 week of gestation if the patient becomes pregnant. During this study, the data analysis was performed using Pearson's or Fisher's exact test for qualitative variables and Mann-Whitney test for quantitative variables. As we see in the table, we can see here the live birth rate is progressively decreased if the duration of estrogen goes beyond 28 days. That is in group 4, those who received 36 to 40 days of estrogen, there is a drastic reduction in live birth rate. And in secondary outcome, there is no effect on biochemical pregnancy or clinical pregnancy, but there is a early pregnancy losses are more significant in group 4, which received 36 to 48 days of estrogen duration exposure. In this study, multivariate logistic analysis was also performed for confounding factors like age, previous ART cycle, E2 administration route, endometrial thickness, embryo quality, and E2 duration. The factors which independently associated with live birth are prolonged E2 exposure more than 28 days significantly reduces live birth rate, maternal age more than 35 reduces live birth rate, and good blastocyst quality increases the live birth rate. Overall obstetric and in neonatal outcome, those with 36 to 48 days group had significantly lower mean birth weight and Z score compared to less than 21 days reference group. Other delivery and neonatal outcome were similar in the all group. So overall, in the discussion, this study is largest of its kind, which says that E2 exposure more than 28 days as a part of HRT cycle is associated with live birth rate. That prolonged estrogen exposure may lead to altered endometrial receptivity or impaired desterilization or implantation potential, and there is an increased risk of early pregnancy loss. This study also suggests a link between prolonged estrogen exposure and a lower birth weight and Z score. There are strength and limitation of this study. Strength, like this is a large sample size which include 1,377 transfer, which helps to reduce selection and statistical bias. External validity is there due to autologous transfer, This is a prospective data collection. Therefore, this strengthen the reliability of finding, and there is a relevance to practice. Therefore, which offers the practical guidance suggesting that estrogen treatment shorter than 4 weeks optimizes pregnancy and live birth chance. There are limitations of this study. Are this one is a retrospective one. Potential bias is there due to logistic and scheduling reasons, which influence E2 duration. This is a single center study which may limit generalizability, and there is lack of data on serum estrogen level during the treatment, and there also they transferred non-selected embryos. So during this discussion at our center, we usually prefer doing natural cycle and stimulated cycle FET. The last option is the HRT FET cycle. At least in India, we hardly go beyond 21 to 24 days of estrogen administration for endometrial preparation. Otherwise, we cancel the cycle. And maybe the patient who need prolonged estrogen for endometrium to develop, there may be other inherent pathology like any persistent endometrial thinness or any Asherman syndrome and all. So with this, we are discussing second paper which focus on that the duration of estrogen does not affect the live birth rate and other outcome. Out of we are discussing furthermore two papers. Out of this, one paper is by Lee et al. With the title is the duration of estrogen supplementation associated with clinical outcome in frozen thawed autologous single blastocyst transfer cycle. This is also a retrospective study from single center with duration from January 2017 to August 2020, with which include 2026 women. Inclusion criteria are those with age less than 38 years at the time of OM pickup, those who undergoing ICSI or IVF. Endometrial preparation is by HRT cycle. There is a transfer of single autologous blastocyst. Exclusion criteria are FET after genetic testing, use of vitrified oocyte, transdermal or oral, and transdermal route of E2 administration for endometrial preparation. And same endometrial preparation is they started estradiol valerate 4 to 6 milligram per day from day 5 of menses. And when the endometrial thickness was more than 7 mm and serum progesterone level less than 1.5 nanogram, progesterone was initiated. Blastocyst was transferred on day 7th of progesterone exposure. In previous study, they transferred on 5th day of progesterone exposure. And then the luteal phase is continued until the 10th week of gestation once the pregnancy is confirmed. They studied baseline characteristic like woman's age, BMI, AFC, endometrial thickness, good quality embryo, for which they categorized patient into three groups. Group A, those who received 11 to 14 days of estrogen exposure. Group B, those who received 15 to 18 days of estrogen. And group C, those who received more than or equal to 19 days of estrogen. As we see in chart, there is a no significant difference on woman's age and BMI in all the groups. But there is a significant difference like AFC are slightly higher in group B, estrogen doses higher and endometrial thinner in group C, and more good quality embryos are there in group B and C. The outcome of this study is primary outcome is live birth rate and secondary outcome is HCG positivity, clinical pregnancy, early pregnancy loss. As we see, there is a no significant difference in live birth rate between all the group after multivariate adjustment. Also, HCG positive cases, secondary outcome like HCG positivity, clinical pregnancy, early loss rate also similar in all the groups. Then other obstetric and neonatal outcome, singleton and twin rates are also similar amongst the group. Then mode of delivery, birth weight, gestation age, and other complication like gestational diabetes mellitus, pregnancy-induced hypertension, C-section, neonatal mortality also do not show significant difference. So at the end, we conclude that it is this one is also largest sample size study, which shows estrogen duration in autologous HRT FET cycle. The mean duration in this study is 11 to 30 days, which did not affect the live birth, obstetric, and neonatal outcome. Clinicians may individualize scheduling of the FET without concern for estrogen duration, impacting the outcome when the endometrial thickness is more than 7 mm. There are strength and limitation of this study. Strength, like there is exclusion of uterine pathology, adjustment for co-founder is done, and it is a large sample size, which reduces the And limitations are like it is a retrospective design, single center study, and not validated beyond 30 days of exposure or in older women. Now, I am presenting this last paper in which they focused on euploid and embryo transfer. Basically, they avoid this confounding factor in this study, transferring euploid blastocyst. The paper is by Sakon et al. With the title Endometrial Preparation Before Transfer of Single Vitrified Euploid Blastocyst. Does the duration of estradiol treatment influences the clinical outcome? This is also a retrospective cohort study from single center, which include 1,439 women with autologous IVF and PGT done with first FET only. Duration is between January 2012 and June 2017. Exclusion criteria are they excluded donor oocyte cycle, prior unsuccessful IVF, thin lining that is less than 7 endometrium, or alternate estrogen route. All patients had adequate lining, single euploid transfer, and standardized oral estrogen regimen. During endometrium preparation, the patient received 2 milligram of estrogen orally twice a day for 1 week. And then, yes, ma'am. Sorry.
Sorry, Amma, sorry.
Okay. During this study also, during endometrium preparation, patient received the estradiol valeric 2 milligram twice a daily for 1 week, then 2 milligram 3 times a day. Ultrasonography and hormonal monitoring done weekly. Serum progesterone level checked to rule out premature ovulation. Progesterone was started 5 days before the transfer, and transfer is done on 6th day of progesterone. Hormones continued until the negative pregnancy test or up to 8 to 9 weeks if the patient become pregnant. Outcome, primary outcome is same, live birth rate. Secondary outcome include implantation rate, clinical pregnancy, early loss, gestational age, infant birth weight, preterm, and multivariable regressions adjusted for our age, BMI, endometrial thickness, embryo grading, progesterone route administration. Power analysis was also performed with 1,092 patients, provided 80% of power to detect 4.3% absolute reduction in live birth rate. This corresponds to an odds ratio of 0.84. So overall result after during this result of the studies, mean estradiol duration maintained was 17.5 plus or minus 2.9 with average range of 10 to 36 days. Overall outcome for all patients were implantation rate was 60.1%, clinical pregnancy rate 55.4%, live birth rate 49.4%, and early pregnancy losses are 11.1%. We overall outcome were with all in significantly not different. In multivariate regression, no effect of estrogen duration on infant birth weight, preterm or term deliveries. However, the study found a significant association between each additional day of estrogen administration and reduction in gestational age at the delivery. So in discussion part, we can say the unopposed estrogen up to 36 days, mean 70 to 80, is safe once the lining is more than 7 nm. Previous study shows conflicting effect in donor cycle, but robust analysis here confirms flexible timing does not alter outcome if the lining is adequate. There is reduction in gestational age per added estrogen day did not increase the risk of preterm birth or low birth weight. And flexible scheduling is possible for logistic or clinical reason without outcome compromise. Sorry. Strength of study is this is also largest study with homogeneous cohort, strict exclusion criteria, and all single euploid embryo transfer. The limitation of the study are this is a retrospective design with short obstetric follow-up until 9 weeks of gestation and non-assessment of cycle cancellation rate or bleeding or premature ovulation, and also excluded patients needing non-oral estrogen and limiting generalizability. So the take-home message is we discuss all the 3 patients. These articles present conflicting finding on ideal duration of estrogen treatment for frozen embryo transfer. So as we can see from the table, one study by Warden et al. Suggests that prolonged estrogen exposure more than 28 days decreases the live birth rate. While other 2 studies by Sekon et al. And Lee et al. Found that no significant difference was associated between duration of estrogen exposure and live birth outcome. Hence, we all need more future prospective study with detailed obstetric and perinatal follow-up are needed to confirm these findings and better understand of the underlying mechanism. Thank you so much, ma'am.
Yeah. Sindhu? Dr. Sindhu,
Yes, sir.
can ask questions or Madam Dr.
think,
Shari is going to comment?
Let
Good
Shari
morning, ma'am's and Sharayu ma'am's expert opinions. Sachin sir also can.
We'll discuss later. If you have any, you can.
Ma'am? Yeah, then good. Thank you. The first case, they only 2 tablets per day. No, so usually we do increase, no, 2 tablets 3 times a day or 2 tablets 4 times a day. No, so like that. We keep increasing the dose. No? That's one thing I wanted to say. And second thing, we do add gel. No? Estradiol gel is available. So sometimes oral administration is not giving any better endometrium. So we do add this one estrogen, no? Estrogen gel, so that to improve the quality of the endometrium. Just I would like to have your opinion, ma'am, about these 2 things. No? Yeah.
Yeah, sir, actually, if we read the materials and method of the first paper, so in that, as you suggested, they started with very low dose. And because they wanted to do it in the batches, they called only patient after 14 to 18 days of estradiol administration. That's why in our clinical routine practice, we are not extending, like, we are calling patient by day 12, 13 of the estrogen, and we start only adequate dose since beginning. Because it's a multi-centric observational cohort study, they started calling patient after 18 or 20 days later. In our clinical scenario, we are not using that kind of practice to start with low dose and continue same dose for a longer time. That could be the reason their first group is only less than 21 days. Where they had actually given it for 17, 18 days. So that just mention how the observational materials and methods can have a different outcome in respect to how we are actually conducting the study. And that could be the bias because when they are starting with the in batches, they have a different estrogen exposure according to that. And even in material methods, like if you see in the first paper, we don't follow after 5 days of progesterone. On the 6 days of progesterone, we transfer the embryo. So even that methodology was different in that particular paper. And that's why we wanted to compare that how your materials and methods can give a different approach when it comes to a outcome. So we never overhead when in our clinical practice was beyond 20 to 24 duration of the estrogen when we start with the adequate dose of estrogen. So you are very right to point out these factors, we never go beyond with such a small dose for longer time.
And so one more doubt, ma'am, out of this topic. No? So what is your experience with this PRP and other like GCSF injections into the uterine cavity?
I think Shariyu, before you take up that question, I just want to point out some things onto this estrogen. It is a very common practice of giving a high dose estrogen in India, number one. It's a very common practice to give a vaginal route or a gel route to have an increased systemic absorption. But if you look at the data, most of the data is saying that when you give vaginal route, yes, I agree, it adds to thickness. But when you give systemic routes, like your gels and all, your serum estrogen level goes up, but not necessarily makes a high impact onto the endometrial thickness. We should remember one core physiological sentence, that endometrium is sensitive to estrogen. It is not specific to estrogen. That means a very good endometrium can be found at 200 picogram of estrogen, and a very bad endometrium can be there at 600 picogram also. So just because estrogen levels are going up, that doesn't mean the endometrium is going up all the time. So I think if you look at the first paper, I think the biggest fallacy, I wouldn't say fallacy, it is the logistic issue. And it's been such a nice gesture by that center. They have presented their logistic issue. Because after 14 days, everybody came to the hospital. They did a scan, but they could not be scheduled for a transfer because of the logistic reasons of they could not take beyond certain number of transfers per day, and Saturday, Sundays probably they were holidays. So inadvertently, some of the clients, because of their own holidays, all the centers policies, they landed up taking more amount of estrogen. And that's what they presented very clearly and nicely, saying that it is not necessary, rather it is harmful. The second part is, so if we say within 21 days, it is a great thing, but in our practice, we hardly give anybody 21 days, isn't it? So we need to fractionate that also. And now, definitely, they don't have the levels, but sir, all of us do estrogen levels. And we love our estrogen levels to be beyond maybe 100 picogram at least, and not very high, not high as beyond 300 or beyond 400 picograms. We require a certain amount of estrogen levels. So giving a large dose of estrogen, especially systematically, if it takes the estrogen very high, that could be harmful. Number one. Number two, I want to say, see, if you satisfy all the estrogen receptors on the endometrium, where will your excess estrogen go? Or where will your excess estrogen act? So every lady, depending upon her age, her menstrual cycle, her BMI, there'll be a certain amount of receptor which is not quantifiable. We really don't know about it. So I looked into some data about giving a high prolonged estrogen therapies. It is a dualistic action. In some women, giving a prolonged estrogen therapy could be a positive finding, but in some women, it could attenuate the endometrium because, estrogen, if you keep on giving it, it upregulates an enzyme, which is called an ubiquitin ligase enzyme. And that is responsible for, it compromises on the mRNA synthesis and proliferative activity. And so giving a large amount of estrogen could actually cause a thin endometrium or a refractory endometrium at the end of it. The second part is, as this study has said, and that is proven in the mice study also, that there could be changes in the gene expression. And they have found gene expression changes with a high estrogen therapy. And the third is, this is something very important to remember, more estrogen you give and more duration of estrogen you give, your progesterone resistance can be induced just because you're giving that much amount of estrogen. No, so all these three things have to be remembered. So reading the first two papers, it definitely says that, a good endometrium developing in a certain amount of time, maybe 11 to 17 days or 16 days. Pallavi, what was the criteria of the second paper, the first quartile of that second paper? That is ideal. Anything you go beyond that, then your results can be compromised. That's how data came with this story.
Using a oral preparation and we do the C levels, do you have any cutoff range? Just now you were saying like anything between 200 to 400 picograms is something very good if you're using a oral. So do you think that, higher estrogen levels, we must cancel the cycle because sometimes we do get 600 or something like that? Is there something that is going to change the mRNA and receptivity there and we should cancel cycle?
That's the right question actually, So let's say you're given estrogen for a period of 20 days, let's say, hypothetically, I don't catch me on these words of 20 days. So I'm telling you a certain small days, number of days, which is acceptable to all of us. And your estrogen level comes very high. Probably it is not detrimental. Now, if you're giving estrogen for maybe 25 days, 28 days, and you suffer a high estrogen, well, that could be detrimental. That's one logical thing which I understand out of this paper. Logic, it is just my logic, again, no evidence I'm putting in front of you. But now you look at the evidence. Because whenever we talk nowadays of luteal phase support and the adequacy of any protocol of the embryo transfer, we will have to talk only one language, and that is euploid embryo transfer. And that is those studies on euploid embryo transfer have said, well, it doesn't make a difference. They have checked all the way to 1400 picogram of estrogen. So we do, let me again put it theologically, cause and effect relationship. That means we advocate doing fresh embryo transfers world over for Posidon 3 group or Posidon 4. So they have 3 oocytes or 4 oocytes. They would have their estrogen level modest between 800 to 1500 picograms. And they, after blastocyst transfer, they get a pregnancy rate, which is non-modifiable by doing a freeze-all policy. Isn't it? That we accept it. All over the world, we accept this. Then why should we be worried about estrogen going up, and canceling the cycle? So in my practice, I wouldn't do that. But in some patients, patients have taken estrogen after estrogen. Like some doctor will give it for, I myself, I would be last 4 months, the patient is taking estrogen because I'm frustrated preparing her endometrium. In that scenario, I'll end up giving her for 4 months of estrogen, and now I may suffer refractory endometrium. That's what I mean by this enzyme and resistance and gene expressions, etc.
So when there are two different routes of estrogen administration, there is no point measuring the serum estrogen levels.
There is a there is a point, but
measure.
I would say I would not like to cancel my cycle just
No,
because
no.
serum estrogen is high. No, that's no criteria to do that. I may just think of adding more progesterone to it.
So, Dr. Sachin, what about the thickness of the endometrium? Is there any limitation for that one?
Yeah, I think I could be quoting
Bari-Sata paper.
yeah, 3 studies here. I could be quoting 2 studies here. One study by your Bari-Sata, a very famous study, 959 single euploid embryo transfers done in an HRT cycle, and they said from 4 millimeter to 12 millimeter.
Doesn't make any difference.
Sir is cut off, Shariu. I think
Yeah, right.
connection.
Yeah,
is-
so the Bari-Sata paper, what they have done, they have taken out the confounding factor. They have transferred the euploid embryo, and that is the best way of doing how the endometrial thickness will really matter in terms of outcome. So they have done HRT program cycle and natural cycle embryo transfer. So wide across from 4 millimeter to 12 millimeter, there was no statistically significant difference.
Yeah.
But very less patients were having less than 4 millimeter or beyond 12 millimeter endometrial thickness. The peak was between 10 to 12 millimeter. And even in natural cycle embryo transfer, it was the same, that all across over between 4 to 12 millimeter, the clinical significant difference was not there when you transfer the euploid embryo.
Yeah.
That was the conclusion.
And the second study was another group. They combined the data. They followed the Bari-Sata study, and they had a UAE center, a Spain center, and a center in Washington. They came together and across different endometrial preparation methods of HRT cycle, modified natural cycle, and natural cycle, they looked at the endometrial thickness and its correspondence to single euploid embryo transfer pregnancy rate. And they said at 5 millimeter, the single euploid pregnancy rate comes down in a HRT cycle and an MNC cycle, but natural cycle outperforms everything. Now, this gives a very clear, because there were about more than 1 lakh embryo transfers there, or more than 60,000 embryo transfers. It gives a very clear message that when you face the thin endometrium, the treatment is natural cycle embryo transfer and a euploid embryo, and not our PRPs and GCSFs and all those things.
So, if you allow me one more question, can I ask?
Yes, sir.
Dr. Kabir? Yeah. Dr. Sachin, I had a patient who had persistently thick endometrium. No? So then I had Mr. Tron did the say came as a receptive. Then the next cycle I had and transferred the embryo. She did become pregnant. No? So what's your comment on this one?
Yeah. So sir, how much? So again, going back to the physiological sentence that endometrium is sensitive to estrogen level.
Yeah.
So my endometrium is more sensitive to estrogen levels. I have 100 picogram. I have 14 millimeter endometrium. Somebody else's endometrium is less sensitive. So even at 200 picogram, she has 7 millimeter endometrium. So it's an individual difference. So at the end of 9 to 10 days of natural cycle, MNC cycle, or your HRT cycle, somebody could be 14 millimeter and some other lady could be 8 millimeter on the same amount of serum estrogen levels. So I think this is physiological things, and we should just accept it, and we should do a transfer. From the ERA point of view, now, please don't misunderstand me. I'm a little critic of ERA. I've been a critic of ERA, because especially after the Cozzolino et al. Himself, the person who invented ERA came out with a paper that personalized embryo transfers do not make a difference. So Neves et al. In 2020 published a very 2020 I could be making a mistake. It could be 21 or so. Presented a paper wherein they looked at failed single euploid embryo transfer data. In the second transfer, they did the simple method, the conventional method, and second group was a personalized method after ERA. And in that particular group, in the second transfer, after first fail, the ERA had lesser pregnancy rate than the conventional method. So there is no way that we should be implementing ERA. ERA, many of us use it, rightly so. I'm not denying that at all. I don't want to be critical of a person here, because we like to close our case. Our patients are so demanding. It is a value-based practice. It's not, everything is not evidence-based. It's a value-based practice. Our patients say that, doctor, do something, do more. And sometimes they put forth to us, can you do an ERA? Because your chat GPT is telling them to do ERA. So I think we want to close the case up, and we land up doing these tests. I'm not denying that at all. But in today's practice, it's not something to be advocated, no doubt.
So with respect to ERA, I just wanted to make a small, input which we had recently. Patient with recurrent implantation failure, having a euploid embryo transfer. So doing an ERA, and we generally do 2 samples. We first send 1 sample and wait. So the result was pre-receptive. You can go ahead and transfer the embryo after 145 hours. Don't have to send a second sample. So since we had another sample, we did send to understand, because sometimes they say the window is very narrow, you do it at 133 hours. So we sent this sample and they said it is out of phase, and in 10% of the people, it can be out of phase. So either you do it at 165 hours or you do a resample. Now, to my surprise, the same patient is for the FET. So I just went ahead and, did the stimulation. On the 15th day, I have a beautiful endometrium with good Dopplers and everything. So it is a very difficult situation to counsel the patient, but all the estrogen levels, everything is good. So I'm going to go ahead and do the transfer for that patient, sir. So it is just a...
Yeah, that's so true, actually. This window of implantation, we're just reading some papers on
Because the endometrium is also quite dynamic. That is one of the flaw for...
Absolutely. Yeah, it is a dynamic thing, and and the beauty of endometrium, it is proliferates or matures. It cannot proliferate and mature. When progesterone comes, proliferation stops. Till the time progesterone is there, the proliferation is on. So, we're just going through a paper, Dr. Shariv and me, we're going through a paper which is, they looked at the window of implantation in the MNC, natural cycle, and HRT cycles. And they first defined a window of implantation, and they defined it as 160 plus or minus 4 hours from the LH surge or the trigger, because they were looking at true natural and MNC cycles. And ovulation, 120 hours plus or minus 6 hours. That was the ovulation. So these are retrospective data. Okay? So whenever they did an out of phase embryo transfer in a natural cycle, the pregnancy rate did not change. The out of phase only in the HRT cycle, and that in the MNC cycle made a difference. HRT was the worst out of that. So when you're doing HRT, you're following up a typical window of implantation of addition of progesterone, and doing 120 hours plus or minus 6 is very, very important. Otherwise, there's a flexibility allowed to us.
Dr. Sachin, can I share one more point here?
Yes, sir.
Yeah, Dr. Sachin, I had a patient, 2 good quality embryo transfers, which failed, and they were terribly upset. So I don't know what to do. Then 3rd cycle, what I did, I subjected for this endometrial receptivity assay. What their suggestion was, we usually give 100 milligrams of injectable progesterone. So what their suggestion was, make it 100 milligrams twice daily, and we did the transfer for that particular woman with that dosage. She did become pregnant. Probably progesterone receptors, we don't do any
progesterone resistance.
You're so right. You're so right.
Probably, yeah.
You are so right, actually.
In that particular, yeah. Tell me, Dr.
No, that's a very, very important message, I would say, what you're giving us. That, increasing progesterone makes a difference. So, don't go by the endometrial thickness. You just increase the progesterone, and probably that will help us in every fashion. It will quieten the uterus. It'll make the progesterone resistance will go away. So we were again reading some papers on progesterone resistance. Endometriosis, adenomyosis, obesity, polycystic ovary are the 4 pathologies where progesterone resistance is well known. Yeah, but 10 to 15%, 10%, not 15, 10% of normal population has progesterone resistance. So how do we identify that? So only weapon in our hand is increasing the progesterone dose. And again, we cannot increase vaginal progesterone, because vaginal progesterone is a rate limiting step. Then they did studies of giving 1200 milligrams and 1600 milligrams. 1600 milligrams had lower progesterone levels. So, the only weapon to increase is either to increase your progesterone or injectable. What you did is phenomenal. That's the right thing to do. Increase the injectable. Very right thing to do.
Good. Thank you so much.
Thank you. That was a wonderful discussion. I was going to ask a couple of questions, but I don't know whether we have time. But
you go ahead.
Please go ahead, Vani.
I was going to ask, is there a lower limit of estrogen when you would think of canceling. And I heard lower limit of estrogen can give rise to miscarriages and all that. And then when you are giving progesterone, I'm a strong believer in measuring progesterone and titrating that dosage when we are transferring. And then I also believe that there is a value if it is lower than this, the implantation rate goes, that is in HRT cycles. Of course, natural cycle is good, but so we have a big bunch of women like endometriosis or postmenopausal and then reduced ovarian reserves, and all these women, PCOS, they are not going to have their natural cycles at all. Anyway, we are going to either stimulate or go for HRT cycles. So when we are doing HRT cycles, we have a definite defined implantation window. And so in that case, if the progesterone value is less than this, it will not implant, and more than one value also it doesn't implant. So I wanted Dr. Sachin Kulkarni sir's input on that. Means
I think, Shari, you
I
take the
practice
estrogen and
I
progesterone
practice sorry.
Shari, your take first.
Yeah.
Yeah, so generally in HRT cycle, whenever the estrogen level is more than 150, will be a better for the pregnancy outcome. As the estrogen level goes lesser, that less than 100, then as sir was mentioning, that a good estrogen, prime endometrium is very important to make the progesterone action and to make it more receptive. And for that, a good estrogen level is more valid. When they have done a study in natural cycle embryo transfer and in HRT
Measure
cycle.
this estrogen, give the estrogen for 10 days and then measure the estrogen.
Yeah, ma'am, obviously we'll go ahead with the 3 parameters, like, where the endometrium is triple line, what is the endometrial thickness? When we have achieved the endometrial thickness beyond 7.5 millimeter in HRT and the estrogen level is beyond 150, then we can go ahead with the transfer. If it is lesser, then we can continue with the estrogen more dose. The absorption rate and the serum values may not correlate with each other. But when it is less than 100, then the chances of pregnancy is on the lower side or the miscarriage on the higher side. Same data Dr. Durga Rao, they have published in Natural Cycle Embryo Transfer, where less than 100 and more than 500 estrogen level, and what will be the outcome. So when it was during that whole 5 groups, less than 100 till 500, more than 500, the pregnancy outcome didn't differ. But the miscarriage were more when the estrogen level was less than 100 or more than 500. So we have different data when it comes to estrogen level, either in HRT cycle or in natural cycle embryo transfer. In natural cycle embryo transfer, the good estrogen exposure in the follicular phase. So one of the paper mentioned that more than 100 kilogram of estrogen for more than 4 days in natural cycle embryo transfer will have better clinical outcome compared to when you have on the lower side of the estrogen. So good maintenance of the estrogen will be will correlated with the outcome related to the pregnancy outcome in that case. What is your take, sir?
Dr.
Yeah,
Shari,
actually,
Dr.
yeah.
Shari, I have a basic question here, in this particular question, where we never we never estimate the hormone levels, either estradiol or progesterone. No? We depend on the ultrasound findings,
Ultrasound, yeah.
the endometrial thickness and the blood flow studies. No, does it really have an impact on our success rates with estimating the hormone levels?
Yeah, I
This
think that's a very important question. And if
yeah.
you're doing your so I'll take this question and then I'll go to the progesterone question,
Sure,
which
sure.
Madam
Yeah.
asked earlier. Yeah. So from the ultrasound parameters are very vital, and I simply go by the simple parameters of the trilaminar pattern, the thickness, and the vascularity component of beyond 50%. That's a Ruffian's classification, and I say 1A alpha is the best endometrium by that classification to go ahead. Now, what is the importance of estrogen level? So suppose we failed certain a case maybe 2 times, or let's say for a month we have a low success rate. How do we evaluate ourselves? So I think I wouldn't like to say in front of for the given client that estrogen level wouldn't make a difference, but for to run our KPIs, to know our quality controls in the hospital, for everything, doing detailed hormonal evaluations very necessary to audit ourselves. So irrespective of knowing that it may not have a great value, I prefer doing all these things because then it keeps auditing, your audit goes very well. And especially if there are 2-3 people doing cases, I think doing this for the audit, unless all the hormonal reports are available, we won't be able to audit our results. So that's probably one of the reasons why I prefer doing this one, the hormonal levels. I would just like to quote one more paper here. This is a paper by George Gusinger's group after he published Lotus 1, Lotus 2 studies. And serum progesterone levels were, just coming up with Elena Labata's study came up at that time. And obviously dydrogesterone is not measured as serum progesterone. So they came out with a very beautiful paper. They gave an HRT cycle. And at the end of the HRT cycle, they shifted on to dydrogesterone. And they, on day 6 of dydrogesterone, they did an endometrial biopsy, wherein they looked at the serum progesterone level in their biopsy. They looked at the era of the biopsy. They also did serum progesterone levels otherwise, and they also did serum dydrogesterone levels. So dydrogesterone is measured at dihydrodydrogesterone levels at PIDA. And they plotted a graph. On the y-axis on the left side, there were estrogen levels, and on the x-axis, there were dydrogesterone levels. On the y-axis on the right side. On the x-axis was the number of pregnancies, the number of women who were pregnant. And the lower quadrant on the left side, where low estrogen level and low progesterone level is there, they did not have a single pregnancy. That really gives us an interact. That means a certain amount of estrogen level is necessary. We could differ on our opinions. Is it 100, 150, 200, 300? Difference will be there. But a certain amount of estrogen level is necessary to get a pregnancy. And a certain amount of estrogen level is mandatory to get progesterone receptor synthesis. So because estrogen is a mitogenic hormone, the progesterone receptor is done by estrogen. So it's necessary. That's how I look at it. Now, coming back to your madam question, the part of the question was about the progesterone levels you were asking. Progesterone level. See, let's understand physiologically. Let's go through all the studies which are done on serum progesterone levels. Everybody says that so serum progesterone level less than 10 is associated with a lower pregnancy rate. So first look at is low. See, progesterone has its own circadian rhythm. The progesterone is also secreted in pulses. So does it mean low progesterone means low progesterone? You stand that lady to be a low progesterone. So Peter Humaydan did a study in his group wherein they had just 10 patients. But through the day, every half hour, they collected blood and looked at the serum progesterone levels. So in 4 patients, they had serum progesterone level less than 10, and those levels did not change through the day. So the high progesterone level fluctuated, but the low did not. That means women who have low progesterone level definitely maintain low progesterone for a longer time. Now, the physiological explanation comes like this. The progesterone in body is bound to corticosteroid globulin, binding globulin, about 50 to 60%. 40% is bound to albumin, and some amount is free. So if you have a high serum progesterone level, a lot of serum progesterone is bound to the corticosteroid binding globulin. So at the endometrial level, there is no corticosteroid binding globulin. So whatever vaginal progesterone you are giving, and it is going to the endometrium, it is free because all the corticosteroid binding globulin is in the serum, and that is already bound. So there is nothing in the endometrium. So your progesterone has probably a better endometrial effect. And that's why having a good serum progesterone level is necessary. So at our hospital, or wherever shall you practice, either on the previous day night or the day morning, we do a serum progesterone level, get a report in 2 hours. We obviously give a serum injectable progesterone after we collect the blood for serum progesterone. That progesterone injection is given to maintain the uterus quiet. And then we do a transfer in the afternoon. That's the regimen we follow very completely here.
Thank you, sir.
Dr. Sachin, I have a doubt. No, when you are giving injectable progesterone, anytime do you find progesterone levels are less than 10 nanograms per ml?
No, so in my practice, I give injectable progesterone only in HRT cycles. But my HRT cycles are very few, sir, just 10%. 90% are MNC cycles and natural cycles. So I don't like
good progesterone maintenance in natural cycles.
Always good progesterone.
Thank you. Thank you, sir. Thank you.
Thank you, sir. With your permission, can we move to the next topic, sir?
Yeah. Sorry for could have stretched it up quite a bit. Sorry for that.
It's my great pleasure and privilege to invite Dr. Vijaya Ganesh, madam. She's an infertility and genetic consultant at New Life Wellness Center. And Madam holds various portfolio and positions in ISAR, and she is our academic secretary at TAPISAR, and she has got a lot of achievements and awards to her credit. We welcome you, Madam.
Thank you, Vasundhara, for the nice introduction. First of all, thank you, Sharad sir, Dr. Radha, and our convener Kundavi for giving me this opportunity. And I here to welcome the speaker Priyanka. Here and the moderator already Sachin sir has been introduced. And sir, here the topic is extended embryo culture to the blastocyst stage in vitro fertilization. Should it be the standard of care? And so we all know, since from the development of culture medias and culture conditions and the lab equipments, we've been shifted to from third day embryo we have shifted to blastocyst culture. Every other clinic is doing blastocyst culture. And this blastocyst culture and transferring the blastocyst will be the one line of treatment that is the same fit for everybody, or even the third day embryo transfer has a player or role? Whether we should go with the blastocyst stage only for all the patients, or does it have any advantages, disadvantages transferring third day embryos? So here we are waiting to listen to Dr. Priyanka, and Dr. Sachin will enlighten with this topic, because still the third embryo has the role, or we should go for a tailor-made fit with the blastocyst transfer. Dr. Priyanka, welcome.
Tahiti, you can stop sharing. Dr. Priyanka, please share your screen. Now is Dr. Priyanka here?
Priyanka?
Yeah, Priyanka.
Is it a Kulkarni sir is here?
I'm there.
Yes, ma'am.
Priyanka is also
Hello.
there?
Okay.
Yes, ma'am.
Yeah,
Please
she's-
share your screen, Dr. Priyanka.
Yeah, we are just waiting to listen.
Am I visible, ma'am? My slides are visible?
Yes, yes.
Yes.
Okay.
Please put it on slideshow mode and start.
The slides. Just 5 minutes, ma'am.
Yeah, take your time.
Am I audible, ma'am?
Yes.
Yes, ma'am. You can click on from beginning, ma'am. Yeah.
Okay. Good evening, everyone.
Ma'am,
I'm Dr.
sorry to
Priyanka
disturb.
Hulge.
Yeah, now it's fine.
Yes.
Ma'am. Thank you.
Should I start, ma'am?
Yes, please.
Hello.
Yes,
I'm Dr. Priyanka Hulge.
your CV is, I couldn't introduce you because your CV slide didn't show up. I just wanted to introduce Dr. Priyanka. Priyanka, she's a senior resident
Yes,
GMC
ma'am.
Kolhapur, senior resident by Dr. Patil Medical College Kolhapur, and she's done her MS OBGYN in KMH Mumbai. Welcome, Dr. Priyanka.
Yes, ma'am. Thank you, ma'am. As we all know, that the blastocyst is having a higher implantation rates when we single blastocyst transfer, we do by selecting a high quality embryo. But when we get a few cleavage stage embryos, the choice becomes dependent on patient age, embryo yield, embryo quality. The suboptimal culture conditions may lower the embryos capable of forming a blastocyst. Nowadays, many clinics have moved exclusively towards the blastocyst culture, assuming that if the day 3 embryo does not progress to blastocyst, it would not have resulted in a pregnancy. So today we are discussing about the paper presented by the Roll Orbito et al. In a Fertile Sterile 2025, and the paper is extended embryo culture to the blastocyst stage in vitro fertilization. Should it be the standard of care? In this paper, he has given the data from 3 to 4 different papers. The data which were taken from the 2016 CDC ART National Summary Report regarding the blastocyst versus cleavage stage embryo transfers, it shows that the live birth rates were higher for day 5 transfers using fresh embryos from non-donor eggs than for day 3 transfers across all age groups. Day 5 transfers shows the higher percentage of the live births per transfer, but the limitation of data is not all embryos survive to the day 5. The next paper presented by the Roll Orbito uh, 2022 is the cleavage stage human embryo arrest. Is it embryo genetic composition or the others? In this paper, he has given a study which he did involving a 30 high quality day 3 embryos who had a single gene defects. Uh, then he grew these 30 day 3 embryos to the day 5, and out of them 18 were arrested before blastocyst stage and 12 reached to the blastocyst stage. After that, he checked the euploidy status of all the 30 embryos, and 19 embryos were found euploid. Out of these 19, 12 were from the arrested group and 7 from the blastocyst group. So the no statistically difference found between the arrested and the blastocyst group regarding the euploidy status. So among 19 euploid embryos, blastulation rates were similar, 58% to 63%, suggesting that arrest is influenced more by culture conditions than the aneuploidy alone. This shows that assumptions about blastocyst development are not fully accurate, and then the debate continues. The limitation of this study was the very small sample size were taken. Good prognosis, when in a good prognosis patient, day 5 embryo transferred, this will shorten time to pregnancy than the day 3 transfer. But for a bad prognosis patient, like advanced age group, poor ovarian reserve, even cleavage stage transfer will reduce the chances of cycle cancellation and will increase the cumulative live birth rate. So from this study, embryos failing to progress to blastocyst stage found chromosomally normal, and hence we believe that in different conditions they would progress to the blastocyst and result in a live birth if transferred them on day 3. So to study more, to look for more about the day 3 transfers, there is a study published by the Ziao et al., which is culturing cleavage stage embryo on day 3 to the blastocyst stage will select the developing while discarding the non-viable embryos. In this study, the question was raised whether transferring on day 3 embryo would benefit more than transferring on day 5. It was a retrospective cohort study involving 1,384 women who met studies criteria. The pregnancy rates, both biochemical and the clinical, and the live birth rates were significantly high in a day 3 group than in a group day 4 to 6, despite the lower quality of the cleavage stage embryos transferred. The study suggested that cleavage stage embryos, which arrest during in vitro culture to the blastocyst stage, could still have the potential to implant if transferred on day 3. There is a large randomized trial, the PRECISE trial, poor embryo yield cleavage versus blastocyst stage embryo transfer. The protocol of this trial was published in 2020. The study is underway to compare cleavage stage versus blastocyst transfer in women with less than 5 oocytes, focusing on a cumulative live birth rate. Uh, Patients with poor prognosis, less than 5 zygotes on day 1 after fertilization. These patients are included in this study. The trial tests if blast embryo transfer is not inferior to the cleavage stage transfer in terms of a live birth per retrieval. It is a multi-center RCT. Patients with less than equal to 5 zygotes on day 1 are involved in the study. 658 women meeting the criteria across 6 IVF centers are involved. The outcome studied in this trial, primary outcome is a live birth per retrieval, and the secondary outcomes are timing to pregnancy, clinical pregnancy rates, ongoing pregnancy rate, miscarriage rate, multiple pregnancy rate. The result of this trial is not available yet. Timing of embryo transfer should individualized considering factors like blastulation rate, patient age, number of embryos, lab success rate, and the patient preference. Progression of cleavage stage embryos to the blastocyst stage known as the blastulation rate. According to the European Society of Human Reproduction and the Embryology, minimum expected and a standard blastulation rates are more than 40% and more than 60% respectively. Key factor influencing the blastulation rate is a maternal age. There is another study published by the Goldman et al. Their data show that with 8 mature oocytes, women's age 34 year, 37 year, and 42 years would average 3, 2, and 1 blastocyst respectively. Thus, age significantly reduces the blastulation rates and affect the IVF outcomes. There is one more paper published by the Iran Zilberberg, is a cleavage versus blastocyst stage embryo. How are they interrelating? In this paper, they have published data from single center retrospect. It is a single center retrospective cohort study involving 3,072 patients and 23,124 embryos at the cleavage stage. They evaluated variables which may predict which cleavage stage embryo would progress to the blastocyst stage. The blastulation rate for embryos at the day 3 was 53.5%. Study found that a higher blastulation rate was associated with better embryo grading and a greater number of blastomeres. 949 patients undergone fresh blast transfer. Ongoing pregnancy rate found 28.9% per transfer. Patients with ongoing pregnancy were significantly younger, 34.3 versus 36 year, had a higher number of oocyte yield, 9.8 versus 9, and an increased number of good quality embryo transferred. When evaluating embryo progression, found that embryo developed to a good quality blastocyst. Its appearance at cleavage stage did not affect the ongoing pregnancy rates. For practical purposes, this paper suggests that each IVF program should calculate its own blastulation rate per cleavage stage across different age groups, as well as live birth rate per transfer of cleavage and the blastocyst stage. If the live birth rate per blast divided by live birth rate per cleavage stage transfer exceeds 1 divided by the blastulation rate, then blastocyst transfer should be recommended. This formula is provided by the Raul Orvito in this paper because whenever we get a low number of embryos and in a poor prognosis patient like poor ovarian reserve or the poor ovarian reserve or the any other conditions. So in that case, it becomes very difficult for us to counsel the patient regarding transferring on day 3 or to growing these day 3 embryos to the day 5. So they have suggested this formula with the help of which we can counsel patient that if we should transfer day 3 embryos or the day 5 embryos. So this is the standard data which is provided, divided by blastulation rate, the live birth rate per cleavage stage, live birth rate per blastocyst transfer, and the live birth blastocyst versus cleavage stage. So less than 35 divided age groups into less than 35 year, 35 to 39 year, and more than 40 years. IVF program performance metrics for demonstration. So example calculations, that formula, they have given the examples for the calculation. For each age group, we calculate the ratio of live birth rates and compare it to the inverse of the blastulation rate to guide the decision. For patients less than 35 years old, if the blastulation rate is 60, 1 divided by 60 is 1.6. LBR per cleavage stage 30%, LBR per blast is 60%. So ratio of blast to cleavage stage become 2. And the conclusion is 2 is more than 1.6. So the blastocyst transfer may be preferred in a less than 35-year-old patient. For patient 35 to 39-year-old, blastulation rate 50%, 1 divided by 52, LBR per cleavage 25, LBR per blast 35, ratio 35 by 25, 1.4. Conclusion is 1.4 less than 2. So the cleavage stage transfer is may be preferred as higher embryo availability is crucial. But for patients more than 40 years of age, as they have already the poor ovarian reserve, blastulation rate is 40%, 1 by 40 is 2.5, LBR per cleavage 20, LBR per blastocyst 30, ratio becomes 1.5. So 1.5 less than 2.5, cleavage stage transfer may be more suitable. So according to this formula, we can counsel the patient whether to transfer on day 3 or to grow them to the day 5. So conclusion of this paper is we can go to the extended blastocyst culture in a patient with good prognosis, young, optimal ovarian reserve, high number and quality of embryos, transferring day 5, shorten time to the pregnancy compared to the day 3, probably without increasing the cumulative live birth rate for that cycle. But in a poor prognosis patients, we have to think about transferring cleavage stage embryos to reduce the risk of cycle cancellation and will give the best cumulative live birth rate for that cycle. Thank you.
Well, thank you so much. Thank you so much.
Yeah.
Any questions?
So I would like to hear from you, sir. So because since now everybody is shifted to blastocyst, and it has been everywhere in all the conference, everywhere they say blastocyst, blastocyst, and still the third day embryo has its role. So what is your take on it, sir? Because as she actually presented, even without that calculation, we can say when there is a limited number of embryos, there is in the age group, in the higher age group, when the less number of embryos, and you think the culture condition is suboptimal, in that case, we can, without that calculation, we can go in for third day transfer cleavage embryo, because the cancellation rate will be higher in those cases with a limited number of embryos and the higher age group, isn't it, sir? So what is your take on that?
I perfectly agree to that. No doubt about it. This is the reason why we chose this paper was to come across this dilemma. That rather face it directly, the dilemma of whether I should go for a cleavage stage or a blastocyst. Like a young lady, when you have cleavage stage embryos, and if the quality of embryos is good, the grading is good, the number of embryos are good, definitely you're going to go for blastocyst. There's no two words about it. Everybody's going to agree to that. I think this question is going to come, but unexpectedly, you have a very low fertilization rate, and you come across just 1 or 2 cleavage stage embryos. I wouldn't even say 3. 3 also, we will dare to go for blastocyst. 1 or 2 cleavage stage embryos, and both are poor quality embryos. Yeah? Or at an older age, when we have facing only 1 cleavage stage embryo, and that lady anyway cannot produce more embryos. So these are the situations which we'll have to answer. The first thing to remember is, can your patient couple digest a cycle cancellation? Okay, now that really varies. Some patients will say, okay, doctor, we want a blastocyst. We are spending 2-3 lakh rupees. Even if you cancel the cycle, we'll just adjust to that phenomenon, saying that, that's our fate and our destiny, that the blastocyst did not form, and we are okay to go with one more cycle. But a lot of clients, for them, doing a cycle cancellation means doctor did some mistake. Okay, and it'll just bombard onto us, and because if you put all these things, that low blastulation rate, One reason will come genetics. They will talk of aneuploidy. They will talk of some other genetic issues which are not testable by all of us. Our genetics are not given us a battery of cluster of genes. If they are present, there would be no blastocyst form. Something like that is not available to us. And the second then comes is culture conditions beyond ChatGPT. And well, they are going to pick that up, culture condition, because that is to be blamed onto a doctor. So unless you then transparently show them the KPIs of your last 6 months audit, these are my KPIs, my culture condition with robust for last 6 months. And we did cases with you, and the KPIs of those patients have been robust. Only you suffered. Then it could be, some adjustment, but who will do all that jugglery? So I think we should avoid a cycle cancellation at any point of time. So in a given situation, when I'm faced with a poor quality or any quality of previous stage, if I have that one embryo to transfer, I'll tell my client, this embryo transfer will give you a very less chance of pregnancy. It may grow in vivo, it may not grow in vitro. Okay, I'm going to put it to the nature. If it grows in vivo and gives you a pregnancy, well and good. The chance is very less as 10 to 20%. Then the client is going to ask me, what else you can do, doctor? I say, you go with one more cycle. With 1 or 2 more cycles, I can offer you some financial concessions, etc. But let's accumulate. And after accumulating, we will take a call. Whether if you have 3 or 4 cleavage stages, then we can take a final call of going to blastocyst all put together. And then we can take that chance. So I think this just needs a thorough discussion. So what we want to tell here, what I liked from this particular paper was, we assume that the embryos which do not go from cleavage stage to blastocyst stage are only because of aneuploidy. But that is not true. Look at that. They had about 30 embryos donated because then they did blastoma biopsy. It was a single nuclear SNP problem. Obviously, SNP problems can grow into a euploid blastocyst, can go into aneuploid also. They allowed them to grow. And in the arrested embryos, still the blastoeuploidy rate in the arrested embryos and those in the blastulated embryos was the same. So aneuploidy cannot be blamed as the only reason for not becoming a blastocyst. In front of the client, probably this is the truth, what we are putting it up. But in our minds of our mind, on our subconscious mind, we must question our KPIs. If you have a good number of eggs and good number of cleavage stage, and if they're not going to blastocyst. So we will have to audit our thing well. And given a situation in a scenario where you have just have one single cleavage stage, or two cleavage stage embryos, poor quality, well, transfer them. You still have a reasonable pregnancy rate, but avoid cycle cancellations at all cost.
Yes, I agree, sir. True, sir. Really, very, very good. And this calculation is also very excellent, sir.
Yeah,
so that we can counsel
Yeah.
the people doing this calculation.
One of the nice parameter what this paper has mentioned that you have to counsel the client and you have to ask them what they are expecting, whether they are interested in only having one baby or whether they want to complete a family. Then that also can be a counseling factor, that whether you want to go for in that case it's better to go for blastocyst because they want to take less number of transport but with better success rate, because they are just chasing one baby. When we want to increase the cumulative live birth rate, then go for day 3 preference more. That's what this paper has mentioned. So the counseling matters, like how the patient is willing and what kind of good prognosis patient we have or poorer. And as Sir said, that a cycle cancellation has to be minimal. And that's why day 3 preference can be given to the client.
Sir, in a young poor responder, sometimes we, are left with only 2 cleavage stage embryos or 3 cleavage stage embryos, and we've had adequate counseling. The couple are, willing for pull-up cycles. So on day 3, most of us will be doing a quick check of the embryos, and if you see that, there's some changes into slight compaction or, very less fragmentation, a good grade embryos, do you, counsel them to say that it's only 2, but still there's a good potential? And if the couple accepts, and many times they have converted into blastocysts because it is young individual. So
I perfectly agree to that. And I always counsel them that please go for blastocysts. There's a very minimal chance that we may not get a blastocyst, but there's a good possibility, and blastocyst transfer are going to get a good pregnancy. And we have made a habit of counseling every client. Well, we're going to go through this procedure and we may fail. And if we fail, what discussion are we going to have? So that discussion will take place before we embark onto a cycle. So, you know,
Dr. Sachin.
yeah, that discussion is done before we embark onto the cycle. It's absolutely properly written in the paper. This is what we
Dr.
do.
Sachin, I always leave the decision to the embryologist. No, they said
Yeah.
if they're not confident enough, they'll say, "No,
Yeah.
doctor, we will go ahead with day 3 transfer." No?
Yeah, that's so true. That's so true. After all, they are the ones who guide and grade us, and they tell, well, they have more confidence than us, where they're looking at the embryo day to day and they're telling us. So I perfectly agree. We do take that chances. Sometimes it's a poor quality or just single cleavage stage. I prefer transferring or requesting them a pooling site.
Sir, in elderly women, do you prefer to do PGTA before transfer, sir?
All 35 and above, I go for PGTA. As I told you earlier, that for the young women also, let people criticize me to any extent, but there is ample evidence that your first FET, if it's a PGTA tested euploid embryo, your live birth rate is better and time to pregnancy is faster across all ages. Beautiful papers have been published in this.
Then
So
how
I
to...
would say, if you fail, that's what I said, if they fail, after
Okay.
transferring a good blastocyst, what am I going to talk to them? I'll say, well, there could be a problem in two things. Your embryo which we put in was bad genetically, or there is a problem with your endometrium embryo crosstalk. For endometrium embryo crosstalk, this is a set of investigations we do, and for this we do PGTA. Then they ask me further, would you like to do PGTA right away? Then I say, well, there is no evidence, but it is a value-based practice. Do you value me doing a PGTA so that you get a genetically normal embryo and increase your pregnancy rate to some? Then they say, okay, let's form the blastocells and then decide. Then they have suddenly 6 blastocells. And then they say, okay, 3 you do for PGTA, 3 you don't. I still agree to that. Go ahead, even she could be 28-year-old. So those 3, one will be euploid. I'll transfer that embryo first and try my best for pregnancy.
So we
I'm
will
open
do
for
this.
criticism. I'm open for criticism. That's why our PGTA, I don't take any extra charges. I just take the lab charges and my consumables, and no extra charges for PGTA.
No, we're just a little worried about the current ART regulations. I totally agree with your thoughts. So are we okay to do PGTA in a 28-year-old in the first cycle, sir? I mean, like...
It is a value-based decision. It is a value-based decision. Like we are doing cesareans for on demand n number of times. Okay, then we have to give them a vaginal trial for everybody for 12 hours and then take a call for cesarean. We do it for demand day in and day out. Okay, so not all IVF need a cesarean. You all agree to that, but we still land up doing that. It has virtually become a consensus. So this was questioned legally to us also, that we were just establishing a unit and we said we have a consent for no egg obtained or no embryo formed. That's been mentioned in our ART consent, but we take an explicit consent of that. And the lawyers did not agree to that. The lawyer of that unit said no. He's a very renowned lawyer, and he said, no, I don't. This is unnecessary. I said, fine, it could be unnecessary from the legal point of view, but I feel it's necessary from my trust point of view. That that we get an opportunity to tell them, what are we doing so that we don't get an embryo? What are we doing so that we don't land up in getting a new cell? What all precautions are we taking for that? And he still did not agree. And there were one more question raised was, now you're taking a consent that no embryos are obtained and you really don't obtain. And they will question you saying that, well, you already knew that nothing can be obtained. You still went ahead with it and squeezed our money. I did not have an answer to that question because I'm not a legal expert. But I think, from the transparency point of view, it's better to take all these consent. That's what I feel. I sincerely feel that.
No, sir, how do we manage this having very few oocytes and in elderly women, and we prefer to, just now we were thinking of transferring cleavage stage and then we want to do PGTA, and how do we balance between the two?
So you look at the studies which are published, and suppose they're beautiful studies, and suppose you have one embryo with you. Will you like to do blood blast and an older lady? Will you like to do PGTA, or will you like to put it to the uterus? So when you put it to the uterus, what are you doing? You are allowing the nature to do the PGTA. And if it is euploid, the nature will assess it. If it is euploid, it will implant. If you don't do that, you want to do it yourself. So you're taking the control of the PGTA yourself. So I explicitly tell my client, we have both the choices. We allow the nature to do it, or we do it ourselves. Assess the embryo and then put for implantation. And then I said, can you digest? See, there's a beautiful paper published on opinions, regrets in IVF. And an action is less regrettable than inaction. So you put up an embryo and you fail. And she said, well, doctor, you had advised me a PGTA. I did not do it. And, I don't know what the reason why I failed. And you do a PGTA and then you say it is an euploid and it failed, they will say, well, you did everything you could, but still I failed. So the regret, both is regret, but the difference is the severity of the regret. And second is you don't counsel them at all for PGTA. Now you fail, and now you start counseling PGTA. They would ask you why you didn't tell me beforehand. I would have done it. So it's a very we really walk on the fence. So when you look at the data published on PGTA tested euploid embryo transferred in older age when only one embryo available, okay, you would have certain pregnancy rate, but you have big cancellation rates. Okay, so is your patient able to digest that cancellation? That's what is going to determine. So why I'm keeping the cost at par, not at par to anything, at par to the expenses I incur. So it is only because more and more women can go for that testing. And if more women go, I will get more pregnancies.
Then we have to culture to
case. It's again a closure of case.
Then we have to culture to blast then. So.
Yeah. So all this, that's what comes to. So, we really have to have a detailed discussion before we embark onto IVF cycle about all these things. So literally my fellows like Pallavi and Priyanka would be sitting with the client and they would explain what are the different, they will draw on paper, what are the different kinds of oocytes we get, what are the different embryo progressions and where we can get stuck. Everything, they explain it on the paper, everything is done. And then we go ahead. So I just put up the protocol and I said, we'll start off and I'll see you at intervals. But my fellows are pretty good. They'll take you to every part is counseled in detail of all those things. And then we push it up further. So it's a team effort. One consultant cannot do. How many counselings will do anyway?
I have a question, sir. So if you have only one embryo, you have counseled the patient for PGTA, and if suppose that embryo doesn't progress to blastocyst, you have to cancel the cycle.
Yeah.
So what will be your next cycle?
Yeah. No. This is not next cycle. Before I reach this stage, I would have counseled a few things. Let me tell you what I call. I'll say, well, I want best of number of eggs because I cannot improve on the quality. I don't know your quality. I can only try to improve on the quantity. So I will try. I would have told him about synchronization. Then I would like to have a better FSH. I would have told him about RFSH. I would have told him about Menopure. I would have told him I want to have an adequate HMG injections. Okay, we'll go through the cycle for nice 11-12 days of stimulation, dual trigger. I tell them the importance of each and everything. Okay. And then whatever pickups, everything. Then we say, okay, your pickup is done. Now we are taking a PhD study on a randomized thing of sibling oocyte study of cult active media. So we put a lot of these women into cult active media. We don't wait for an embryo not formed and then put into cult active media. We electively put into cult active media. We use microfluidic sperm separation by everybody. It will be used universally. Because your sperm DNA fragmentation is also a reason for cause aneuploidies. And if you're targeting PGTA, you won't need more euploid. So when you look at the male factor studies and aneuploidy, it's only the sperm DNA fragmentation beyond 30% has aneuploidy. Otherwise, that's why it is related to miscarriages, more miscarriages. Well, all of the sperm factors have no relation to aneuploidy status at all. It is universally true. So we say we will be doing microfluidics so that your HAP-SELECT trial did say that the DNA fragmentation does go down. So all this comes still to them. So they know when they have not reached the blastocyst, the doctor has taken all the care. So before the first blast is not formed, we have explicitly told them why it did not form and all the care which needed to be taken has already been taken.
Dr. Sachin, I want to make a comment in a lighter way. I want to change my opinion about the proverb. No? Ignorance is bliss, they say. But now I change my opinion. I say knowledge is bliss. No? Thank you so much for your extensive knowledge on this one. No? Thank you. Yeah, Vijaya. Yeah.
My thing is not cleared. Sir, Kulkarni sir.
Suppose you don't form. So after all that counseling.
So the next cycle, sir. Next cycle.
Yeah, next cycle. I said I've done everything. Now I come back to the one of the papers like when you should give growth hormone. So they looked at what DHA can do, what coenzyme Q can do, and what growth hormone. Growth hormone corrects the embryonic issues. So the next cycle, the only addition which is left, which is not given in my first cycle, is growth hormone. So I'll tell them, will please take 12 or 15 days of growth hormone injections, and then I'll take you up further.
Okay, so then next.
The rest of the corrections I've done in the first cycle itself.
Is there any place for donor oocyte, Dr. Sachin?
No, sir. My donor cycles are, believe me, only 3 a month.
Okay.
Yeah, my donor cycles are very, very less. Even at Sharyul's place or wherever we are, our donor cycles are pretty less. That's why this time we're conducting a reproductive physiology workshop. I'm taking 2 lectures, one on window of implantation and one is on embryo pooling. Because that's absolutely the need of the day to understand those concepts very well.
Yes, sir.
Yeah. And window of implantation, there is no dedicated lecture on window of implantation. I feel so much needed. That we need a complete lecture on window of implantation, like how to assess it, what parameters, when you can get the best, etc., etc.
So just wanted to ask one question. What is your opinion on if you're freezing on day 3 and you want to culture them to day 5 later, if you're planning for a frozen transfer?
Yeah, correct. That's a usual thing we do. Suppose we have, let's say, 2 or 3 cleavage stage. We do many a times opt for freezing, especially if they're of a low quality. We said they're of a low quality. Let's freeze them then. Now, take them to a metabolic rest. And you give me a call. I just tell them you take a call whether you would like to go for one more cycle. Okay, because all these decisions cannot be taken rapidly by the clients. So I tell them you come after 10-15 days. We'll discuss 2 things. One, would you like to go for one more cycle? Then we have 6 cleavage stages probably, and then forming a blastocyst is more possible. Or would you not like to do a second cycle and allow them to go for blastocyst, or allow them to be transferred as cleavage stage? So this is discussed and it's a shared decision making between the client and us.
Now, suppose you get the 3 good blasts, you counsel them again for refreezing them?
Yeah, so yes. Suppose I never transfer beyond 2. So 2 are transferred and 1 is refrozen again.
Okay.
Radha, time to vote of thanks.
Yeah, yes, sir. It was a wonderful discussion. I thank the chairpersons, Dr. Vani Pujari and Dr. Vijaya Ganesh, and the speakers, Dr. Pallavi and Dr. Priyanka, and the experts, Dr. Sharayu and Dr. Sachin, for this wonderful discussion. And I think many of the audience have, many of their queries have been cleared. And it was a very good discussion. And I also thank the Shield Healthcare for this wonderful platform. Thank you, one and all.
Yeah, thank you so much for inviting us. Thank you very much.
Thank you, sir.
Thank you.
Wonderful, sir. You
Dr.
cleared all
Sachin.
of our doubts.